All right, ladies, I'm really looking forward to this conversation. I was thinking about it today and thinking I've been planning this for probably almost a year now. So I'm glad that we're actually able to make it come to fruition. I have spent some time getting to know your company and just what it stands for because I knew that there's a lot of controversy behind this topic lately, and I know you're doing it differently. So I really wanted to do this topic justice. And so I've spent some time. Sinead and I have talked many times in the past, just about what she's been doing. And then Erin, I was introduced to you probably about a year ago, and we had a discussion around Urospot and some of your plans moving forward. And also too, I've talked with Nia, who I know does a lot of the physio coordination. And so I've really enjoyed getting to know your company. And I'm excited for you to share with everybody today. So we're obviously going to be talking about, I think a lot of people listening to this will have heard of the Kegel chair before. And I use air quotes because it's not obviously called that, but people know it as that. And I think that there's a lot of thinking right now around, is it good or is it bad? I think sometimes physios have a hard time digesting it. And so today we're going to really dive into what exactly is it, and what are some, good indications for it, and maybe what are some times where we need to be thinking a little bit differently. And before we get there, will you both take some time introducing who you are for the listeners, and then we'll get into the topic.
Sure, I'll start, Mel, because I've been on your show before, so I can probably be pretty quick. But hi, everybody. I'm Sinead. I'm an academic clinician. So I spend a lot of my academic time with McMaster University, and then a lot of my clinical time with the world of my baby, but also with this really cool collaboration between Urospot and Compass Rose Wellness. And I do some other different things with other companies, really, who all kind of have the same mission. And it's to kind of help as many sort of women as possible, sort of like with these pelvic health concerns as they go on. That really is my mission, is to do that in whatever way I can. So that was really the impetus of how Erin and I connected. So yeah, that's a little bit about me.
Awesome.
And my name's Erin Craven. I am the founder and CEO of Urospot. And I started this company for many reasons, but one is because of I feel I am a champion of women's health. I've worked in healthcare for, now 25 years, basically, and mostly on the business side. So I've worked in women's health and respirology and dermatology. I ran a pharmaceutical company for over 10 years. So I really do have, from the business side of things, a solid understanding of healthcare in Canada.
That's great. It's interesting. I actually recorded an episode not long ago about with someone, and she's a physiotherapist in BC, but she's doing her PhD kind of in the business of physiotherapy. And it was a very interesting conversation because she said we are business people, even though we don't want to we feel uncomfortable somehow saying that, but we're business people, we deal with clients. And so I think it's a really interesting, partnership, and to be able to kind of come at it from two different angles or two different areas of expertise, right?
Definitely.
So I thought it would be helpful to start off the conversation meeting people where they're at. And I think I always say in a lot of podcast interviews, like, we're learning as we go in healthcare. And I think we're quick to make judgments, and a lot of marketing is angled a certain way. But what if we start a little bit with some of the things that people will have probably heard before that are listening to this? We're going to be talking about, the emsella chair and how we can integrate that with physiotherapy, but that's a new concept for people. Right now, they're two separate things. Will you ladies talk a little bit about what you assume people are hearing right now before we get into your concepts? What are people hearing right now that, in the media or in and amongst themselves about this topic?
You want me to start, Mel?
Sure.
So what I would say is, and this is really kind of from my PT lens, but I would say probably what people are hearing is that, hey, there's this solution for these pelvic health issues. And really, I mean, incontinence is kind of like the big one. And it's just as simple as kind of using this tool, and this will kind of fix all your problems. So in ways, if we're going to dissect that a little bit more, and I know Erin's going to have a lot to add to this too, is in ways it's actually a very, very good thing that we are talking about pelvic health issues, that this is a big problem that's been kind of locked in a closet for a long, long time. So, I mean, I'm actually kind of grateful for any type of innovation and conversation maker in this space, right? But then kind of once we're talking about it and we have these different options on the table, then it's important to kind of interrogate sort of like, okay, well, what is this tool for and how might it help and how might that marry with other options, right? That's always where my brain goes. So certainly, do I like that there is more innovation and more options on the table? I think that's great. I think the place where a lot of PTs get tripped up with this particular technology, and maybe the same could be said for other technologies for pelvic health and pelvic floor fitness capacity, is sometimes around the messaging. And I always kind of say, like, we don't want to throw the baby out with the bathwater. Like sometimes just around the messaging in terms of simply just do this and it will kind of fix everything for you. And of course, as PTs, we know that's not how health works. We know that's not how biology works. And so that can feel a little bit frustrating, right? So I think that's probably the biggest thing I'll start with in terms of what kind of we're hearing, how emsella can be marketed, and why I can appreciate why some people kind of, it leaves a bad taste in their mouth.
Yeah, because I'll tell you, I think that one of the most common things that that maybe I'm asked as a physiotherapist is like, have you heard of that chair where you just sit on it with your clothes and it gives you 11,000, contractions of your pelvic floor in 28 minutes? Like, does that work? That's probably a really common question that I would get asked. And then of course, as a physio, well, and I've learned a lot as I go too. So there would have been a time where I'd be like, that there's no way, how would that work? But then obviously we use modalities as physiotherapists a lot. So you have to stop and think, okay, what is happening there? And sometimes I use the analogy of, we use muscle stimulation for people. Like I did a lot of stroke rehab, and I might use muscle stimulation at the beginning when I wanted them to be able to isolate or feel a muscle, but I would never put muscle stim on them on a chair and then say, now you can walk, So I think I said, I can see that there's probably some intention there, but I think that was a hard time as physios, or like, there's no way that is going to be the answer to their prayer. So I think that is the most common thing. Erin, what are some other things that maybe you think listeners have heard before on this topic that we want to dispel?
Yeah, one thing I think is important to point out too is just what the lay person out there is hearing is so much about menopause, right? Menopause is getting its day in the sun right now. Pelvic health is getting its day in the sun. There is so much more attention and media. I keep calling it a pelvic floor revolution that's starting to happen. And that's wonderful, right? Women are more empowered. There's this underserved reality of women's healthcare that women are starting to say, wait a second, like that doesn't make any sense anymore. It needs to change. And so there's just this kind of groundswell of attention, I feel, in this area. And with that is going to bring more awareness and noise about how to deal with these problems too, right? So I do think we have to recognize that that's also going on in the world right now, which I think is actually a wonderful thing, because help seeking, as you all know, in this space has been so low for so long. And women who do finally get the courage to go help seek are typically, at least in the health, typical like primary care world, sometimes dismissed, right? So that is happening. And I think that's also creating all this other noise and opportunity that might be helping physios get their back up a little bit, because they're hearing about technologies that maybe they're not as familiar with.
Absolutely.
And I think that's the key, is to become familiar, to really do your own homework and learn about it as much as you can, so that you can have the right information, because there's definitely incorrect information out there too.
Mm-hmm. Absolutely. And that's kind of part of the reason why we do this, is to help explain this option, right? I think another thing too that people hear, just if I think of some of the messages that, or the questions people ask, are around, that this would be a standalone treatment, that you just go for maintenance. You go kind of, I don't know, every once in a while, but you need to keep going, and that you would maybe choose this over something like physiotherapy. I think that's another thing. It's like, how do I know if I go to physio or if I try this? Yeah, I think that's another one I hear a lot of.
For sure. That's out there, right? And where you go, I always say this technology has a place in care. What matters is where you go seek care.
Mm-hmm. So what if we start getting into, because I think that's my interpretation of it, is that we used to maybe just not understand it as well. And now we're starting to understand a little bit more. And I think overall, the message that we want to get across is that your company has built a care model that incorporates both, education and kind of physiotherapy coaching and technology. And so I'm interested if you share a little bit about, how did you get there? How did we get from, that it's just a chair that you sit on and you receive all of these impulses, to, oh, maybe this is helpful and maybe we can marry physiotherapy and education. How did you guys get there?
Well, I mean, if I back up to the very beginning, when I decided to create this company, from day one, I always viewed this as collaboration, not competition, right? It's not one or the other. It was always collaboration in my mind. And I was naive on that point coming in, because I didn't expect the reaction from physios initially that there was out there. I assumed there is so much need for care out there, and that my superpower that I can bring to this is actually improving help seeking. Marketing is something that's my background. I know how to do that. I can help bring more attention to this. I was a woman who needed this help, and I didn't know where to turn for that help. So I knew there was room to improve that. And so I always thought, oh, this is great. I'm going to help rise the tide. And all these boats, all these community PTs are going to get all this extra, intake as well with clients, because I'm going to really try and help improve help seeking. That was my naive start to this. And I quickly learned, whoa, okay, I'm not really welcome to the club, is how I initially felt, if I'm being totally honest. There was some pretty cool responses. Cool being temperature.
Yeah.
And and then there was the odd physiotherapist that called me and said, can I come in? Can I meet you? Can I see what you're doing? Can I actually learn what you're about, instead of just making grand assumptions? And when those moments happened, I realized, okay, they left with a totally changed mindset about me, my intentions, what this company was going to do, what I thought the relationship would be. And, the blessing in my life has been that Sinéad was one of those physios who was like, wait a second, I want to come understand this more, and took the time to do so. And what happened from that point on is this ability to actually more formalize what I had said, which was collaboration, not competition. I knew enough about the technology. I've worked in innovation forever, and that it wasn't the answer for everyone. But what Sinéad and I have been able to do together is to create what we continue to call pelvic health done differently. We're doing pelvic health care. We're just doing it in a little bit of a different way, but it's allowing for it to be technology, if the client so chooses, plus education, plus health coaching. And the one analogy, we're all moms here, so I'll say, I know how hard it is. We probably all struggle with getting our kids to eat vegetables, right? It's hard for physios to hear this, but the absolute truth sometimes with certain people is that they don't want to see a pelvic health physiotherapist. Mm-hmm. They don't want to take their clothes off, right? That the term pelvic health physio puts their back up. And there's a large population of women out there who do feel that way. And so what we're doing at Urospot is pelvic health physiotherapy. So we're kind of sneaking the vegetables into the dinner, right?
Mm.
Like that's what we're doing. We don't maybe help them. They don't realize maybe in that moment, oh, this is pelvic floor physiotherapy. But through all the education and all the health coaching and the individualized care that they're receiving, that is pelvic health physiotherapy. So they're getting their vegetables just in a different way.
Absolutely. And I think we all have to learn to keep an open mind. And like you said, not no two people the same. And it's important for us to listen to what our clients want, and they don't all want the same thing. Sinead, I feel like I didn't I learned this from listening to you talk somewhere else. Can't say I remember where. But I think you were talking about your introduction to this technology. Maybe it was at some sort of symposium where you were listening to someone else talk and they were talking about maybe this HIFEM. I might be getting this wrong. That was when you opened your ears to, oh, interesting. What is this doing? Do I have that right? And that maybe is what piqued your interest?
Yeah, absolutely. So you have that right, Mel. So I had kind of first seen the emsella chair, the HIFEM technology, at a conference here in Canada, the Society of Obstetricians and Gynecologists of Canada. And it was just at an exhibit booth, right? And I must say, you know, I even kind of myself felt a smidge dismissive of that. And frankly, other kind of technologies that were there at the time. I was with a Urogyne colleague of mine at the time, and I give her full credit because as I had a very dismissive attitude as I walked by, she was the one who kind of stopped me and said, "What are you doing? You know, we don't want women with these issues to end up with surgery and medication and seeing me like we want as many conservative care options as possible and get off your PT ego. You are not the only game in town. You do not own the pelvic floor." And that I think was a really important moment for me because I think I did have that attitude to a certain degree. And I see that attitude with my colleagues. And I think it comes from a good place, but it ends up actually being unhelpful, to be honest, right? So that was actually my first kind of, you know, introduction. But it was literally, I think, a year later at the IUGA conference that I saw this company was running a session through the lunch hour, presenting all the interim results of the trials that had been run. This was right before COVID hit. And I was there with actually a different Urogyne colleague, and we were both in there listening. And actually what really struck me was the interim findings indicating that even though the populations that were targeted were for incontinence for this particular tool, actually, given that, you know, the pelvic distress inventory 20 was run in a lot of these studies, right? It's a psychometrically sound outcome measure. Well, we get a whole array of pelvic symptoms outside of incontinence. So we get some really good insight even around things like painful intercourse and sexual health. And what was really interesting to me was not only was the incontinence consistently improving, but also urgency was improving and also painful intercourse was improving. And for me as a physio, that was an important kind of aha moment. And that made me realize that sometimes the way this tool is marketed is going to be problematic for physios, unfortunately, because it's marketed as repeated Kegels, which isn't really actually what the tool honestly does. And to a physiotherapist, repeated Kegels will increase stiffness in the tissue because that's what it's supposed to do. And you would never have a goal to increase stiffness in tissue if there's dyspareunia or if there's urgency. And so it just made me realize, so clearly that's actually not what's happening. And I, of course, then did my own homework to learn a little bit more and got really excited about this tool as an amazing adjunct, right? Because I got to learn what it was actually doing. But that was an aha moment for me. And it helped me to even understand sort of further, you know, okay, I get it why PTs think what they think, but we really do have to dispel some of these myths. I mean, to the credit of BTL, who's the manufacturer of this tool, I understand to a certain degree why it makes sense for them from a help-seeking perspective or marketing perspective to use the term Kegel. Because really that is what the lay public associates with kind of contracting the pelvic floor. And so I can kind of see both sides. I still think in some cases, the marketing, the way some people are doing it, honestly needs improvement. I really do. I do think more clarity in terms of what the technology is actually doing, like needs to be sort of, clarified a little bit better. I think that would help our PT colleagues. But absolutely, that was an aha moment for me. And then I've had a chance to kind of see this technology integrated. I'm not a fan of it standalone, but I'm not a fan of any technology standalone, right? I've had a chance to see it integrated and see like the outcomes that were presented exactly match the outcomes. If not, actually, the outcomes honestly are even better with Urospot because there's the health coaching piece, which I think is like really where it's at. But yeah, it's been really, really cool to see.
So do you think then it does boil down to the marketing? Because I think about all of the modalities we use in physiotherapy. Like even the other day, I was using kind of TENS for tibial nerve stimulation for overactive bladder. And I know TENS is different than this, but it's a modality. IMS, we use muscle stim for other things. IFC, like different physios will use that always as an adjunct. You don't see it used alone, whether it be followed by exercise therapy or education, behavior change suggestions. Why is this, and we don't have our backup about that? I mean, I think we do if it's used solely as the only treatment option. Why do you think we get our backup about this then? Is it the marketing? I think that's what it sounds like you're saying, is that it's an issue with marketing that we hear, like you said, Kegel, Kegel, Kegel. Oh, that's not a standalone treatment.
I would say Erin's going to have some great insight on this. So I'll just say first, I think it's a couple things. I think it's one, the messaging around Kegel, and then PTs quite legitimately, thinking that, but Kegel's is never indicated in this clinical scenario. So I think that's part of it. I think the other part of it is the messaging around simply passively do this, sit on a chair and blindly read a magazine. And so I think that's another issue. But I think another big issue, and like this used to drive me bonkers as a physio when I would have physicians say this to me in terms of trying to decide for patients or clients how they should spend their money. And the messaging often is said to me as a teaching physio who I go around to different places is, okay, this is on fine and dandy, but none of our clients can afford physio. So like, and these practitioners are making decisions about someone's wallet. And I find physios do that about this tool.
Absolutely.
Because this tool has a higher price point, it's really interesting. All of a sudden, our colleagues think they can be making decisions for what's valuable for someone's money. I mean, forget the fact that we know that incontinence products in just a year is $1,500. So, I mean, who are we to say how someone uses their money if they're completely rehabilitating all of their biological systems, including their pelvic floor, because they're getting amazing health coaching and additional tools for impeccable fitness capacity development of their pelvic floor. I mean, they're never going to need to spend another penny. So like you've just saved them money. So I think it's those three things, really and truly. I'm sure Erin has some things to add.
Yeah.
No, I think you're exactly right. I mean, the cost piece we also hear in like with physicians, they don't like to ever talk about the cost of something in Canada with their patients too. So they just would rather avoid that discussion. The only thing I'd add to there, and I think this to me, I totally get it. It's like when LASIK surgery first came out about 25 years ago, and optometrists were very threatened by that. So I get it. When new innovation comes out, it can be threatening when it's your livelihood, right? That it's like, well, wait a second, if that truly is that easy and that's all it is, oh my gosh, that can put a little bit of fear and doubt in a PT, which I fully respect and get. But here we are 25 years later, and both exist in the like the LASIK example, no problems at all, right? So that's the only one I would add to the list of why.
It totally makes sense. And so then let's talk a little bit about like when I'm trying to decide whether we should start first. Like, when is this indicated? Where does this fit? Because obviously we always look at, okay, someone comes in with a symptom. We need to look at kind of where do we start? We often have a place that we start with our treatment. And I think that what we're going to get at, one of these things we're going to get out of this discussion too, is we'd never just sit someone on this chair to start with as soon as they tell us that they have incontinence. What if we start really quickly, like where does something like this technology fit in like evidence-based care? Like when are we supposed to apply this? Because I know, there's certain things that if I was seeing someone, I wouldn't say, oh, you're incontinent, let's set you up for this treatment first. But will you talk a little bit about that so people understand, before we talk about what this treatment actually looks like, can we talk about when it would be indicated?
Yeah, absolutely. I can speak to this. So we're fortunate specifically, in the space of urinary incontinence, that we have many conservative care strategies that have very high level of evidence, right? We don't have that, honestly, for a lot of areas of physio. We really don't. But we have that for incontinence. And so we have a number of what we call our level 1A strategy care strategies. So this is where we know that multiple randomized trials, so we now know meta-analyses, systematic reviews, all kind of confirm that this has very good efficacy, right? So of course, if we're kind of talking about incontinence, right, which I think is an important place to start with this tool, that is where we start. So what are our level 1A strategies? Well, it's a variety of different lifestyle interventions which require health coaching to enact those properly. It is individualized pelvic floor muscle training, which means you need a healthcare provider with expertise in that, providing guidance on that, right? It is bladder retraining and really understanding that side of things, particularly if there's urgency or frequency. And it is the use of internal vaginal devices. These are all our level 1A strategies.
And Sinead, can I interrupt you and say, like, you mean
yes,
like a pessary, right?
An incontinence pessary,
yeah.
exactly. Mm-hmm. So the one that actually has the highest amount of evidence that kind of informs the Canadian guidelines, for example, is a tool called Urospot. Okay, but it's like a little small incontinence pessary. So yes, we should be starting with these things, our level 1A option tools. That having been said, every single person is different to their response to care, but frankly, different in their preferences. So, someone might come forward and say, yes, get it that, this pessary might be really good because I'm having a lot of leaking when I'm exercising. That's a specific indication for these pessaries where the evidence is best. Not interested in anything going inside me, not interested in anything like that. We have to take in people's preference. That's one of the legs of the stool of evidence-based care. So, people's response to care is different and people's preference is different. So then I would be saying, okay, then from there, we need to go to the level 2 strategies and then the level 3 strategies. Well, when it comes to electrical muscle stim for the pelvic floor, we have a global grade of evidence of level 2, right? So it's that next level. That having been said, a tool like emsella, HIFEM technology, is a bit distinct from standard EMS for 2 reasons. One, it's more focused, higher intensity, but 2, it also has a magnetic component into the energy that's entering someone's body. So in a scoping review that is in press to be published right now, through that analyses, we did actually like a sub-analysis of all EMS for the pelvic floor. We did a sub-analysis. I think there was like 6 or 7 studies looking at HIFEM technology, and we actually see that it's superior. You get the same outcomes in a much shorter amount of time. And so it's unclear, is that because of the magnetic component? Is that because it's higher intensity? Some of the data points to it's probably more related to its higher intensity and quite focused. That's kind of where that leans. But we can feel confident categorizing all EMS as level 2 strategy, but maybe even like a 2+ if you're using HIFEM. There are kind of so far seem like there's established benefits there. And then there's other like level 3 strategies. A level 3 strategy I'm a huge fan of is a company called SRC, their Restore product. So their Restore product, that it's external compression for mild incontinence and prolapse symptoms. That would be grade 3 or level 3 evidence, but I'm a big fan of that product. And again, sometimes for people's preference, they like the idea of jumping on online, ordering it themselves, using it themselves. It's really empowering. So I think we have to consider a lot of things, but I do think every PT needs to understand the levels of evidence of everything and do their own due diligence there. But they also have to understand where we need a degree of flexibility depending on someone's accessibility to something, their preferences, etc.
Yeah, and I think that just to point out that what's confusing for the consumer or the layperson is that this technology is often most often offered as a standalone treatment, like so that a lot of these chairs are being set up in so many different settings. Like we're going to get into the details of your company because I know you're doing this differently, but this is not happening everywhere. And so these chairs or these modalities are being set up as a standalone. And so sometimes people sometimes will say, oh, it helped me. And so it doesn't mean, it could help some people, but I think we tend to also say, oh, it didn't help them. They're still having incontinence. But a lot of these people will be going straight to the technology without addressing some, like you said, the level 1 options first, that quite often can be very successful. But is this modality, to simplify, like any modality, is kind of like almost like a reboot to our system, a conversation with our nervous system, like just a different way in, correct? And
Mhm.
and
I
so,
would agree.
yes,
Yeah, the neuromuscular re-education that's happening, Melissa, when I'm describing it to the layperson sitting in front of me, I talk about it's almost like a reboot, like we're turning the
exactly.
computer off and on again. And we talk about why that disconnect can happen and then how can we reconnect it. And that's why you might hear these stories of somebody who went somewhere that's not really a specialist in pelvic health,
Yeah.
where somebody did have an amazing immediate kind of neuromuscular reboot. That does happen, but I can tell you, because nobody's treated more people in the world than we have with this technology, that doesn't happen to everybody. It's not an immediate for everybody. It does happen, but not on the first session, like you'll hear with some of these people you're talking about.
Yeah. And so then can you talk a little, this kind of segues nicely into your care plan. So what does Urospot do differently? So again, keep in mind that a lot of people listening to this, all they've heard of is the emsella chair. Okay. So I think it's important to differentiate that you are not emsella. Like Urospot
Oh,
is not synonymous with emsella. Can you, as we kind of segue into what is Urospot and what are you doing, can you just differentiate for people the difference between emsella and Urospot?
Yeah. And just to start, I do have the same concerns as you with people going to seek care
Yeah.
at some skin clinic that does Botox and happens to have a chair in the corner. And it's like,
Yeah.
would you like some fries with that?
Mhm.
That terrifies me. And that's my biggest frustration with the manufacturer as well, is that they are selling it to people who are not experts in pelvic health. So I'll just say I'm on the exact same page as you with that regard. Yeah, we are not emsella. And if you go on our website, I would challenge you to find the word emsella. We do not talk about the name of the device. We talk about the fact that Urospot uses technology, education, and health coaching. We don't name the technology. I know you can see there's a cherry, like we talk about how the technology works, but we are not emsella. We are Urospot, and we are the place you go to help solve these problems. That's really what it's about. And so, like I've been saying, it is this combination, this care model that if the client so chooses, they can use the technology, but they can also just do physiotherapy. They can do both. And there are many people for whom this technology is not a fit. They may have a contraindication to the technology. There may be other reasons that it is not a fit. And nobody leaves Urospot without a hope and without a plan, right? So we have a way to serve the market. The technology is a component when for the majority of our customers, for sure, our clients, for sure, but it doesn't have to be.
So, Erin, can you explain, or either whoever this question is most appropriate for? So, let's say I'm a listener to this, and I'm a physiotherapist that has someone in mind. I think, I wonder if that would be an idea. Would you say, first of all, where are most people coming from? Do you think it's website searches? Are they being referred from physiotherapists? I want you to speak a little bit to that. And then where would someone start? So let's say someone listening does have some incontinence. and they want to know what's it going to look like when I come into your place.
So when you, excuse me, when you come to Urospot, we start with a pretty comprehensive assessment consultation. It is qualitative and it is with a registered nurse. And what we are doing in that appointment, and it is complimentary, and that's part of just my company as a platform, is I want to empower women and men. We treat men as well. But whether you decide to do treatment with us or not, you're going to leave that 40 minutes feeling very empowered and learning something new about your body. So we're assessing if the client is a fit for the technology. We're going over their symptoms that they're experiencing. We're trying to get a sense of, what they're struggling with, what's going on, what could be causing it. We're going pretty deep on that sort of stuff. We are going over, obviously, making sure they don't have any contraindications. And then we're doing a lot of education. We're educating on what is the pelvic floor? Why is it important? How does it dysfunction? Going over exactly if prolapse is what they're dealing with. We're doing a lot of education on that. And then we're giving them options. Here's how you can go about seeking care. One of the ways is to have an assessment with one of our pelvic health physiotherapists, and you'll get an individualized care plan, an individualized treatment plan. If you so choose, if they want the technology to be a part of their care plan, then we'll put that in separately. It's separate from the physio. And so that's one way to do care. And then we also do care with one of our nurses leading the care, and they can just use the technology. But if you're just using the technology at Urospot, like I said, you're still getting the vegetables in the dinner. There's education throughout. There's health coaching throughout, world-class level, that Sinéad was a huge part in helping us develop.
So basically, they're not just sitting there with a random magazine, they are in a lot of places. It's a little bit more, okay, now I'm getting this, let's call it a reboot. I'm getting this reboot, or I'm getting this messaging into my pelvic floor, but I'm also learning a little bit more how to change my behavior or like my habits, understand how these muscles work, understand why incontinence happens. Am I right?
Oh, you got it. Empowered and educated is what we go for. And we always have these comment cards at the end for women to leave their story for the next woman to read, because I think that's very important about women helping women. And the cards, like, notoriously now say, I learned so much. I learned more in these appointments than I've ever learned at all my doctor's appointments. And what I'll add to that, Melissa, is that we always start every appointment with breath work. So we're doing diaphragmatic breathing. Women come into these appointments just totally spun, right? Their days, we know how busy moms are, and we need them to fully relax and be ready to receive this energy. And then what we also do before treatment and after treatment is core breath. So we're teaching them how to actually use the muscle properly, so that when they finish at Urospot, I always say, yeah, you're going to have more fitness capacity in your pelvic floor, but you're actually going to now know how to use it. So when you go to cough, lift the baby, sneeze, whatever it is, you're going to be able to engage that muscle. That's not passive. And I've been accused of that. So that's why I'm happy to get the chance to say that, because it is not passive treatment.
Well, and again, I can't say enough. I just think we're quick to make judgments and we're quick to say good or bad, and without maybe understanding. But again, you're kind of, let's say, I can imagine you're up against it a little bit because of some of the way that this technology has been used before you, right? Is you
Oh,
kind of have to keep, probably, I'm sure, kind of explaining yourself a little bit.
to be honest, I'm BTL, the manufacturer, would say I'm the biggest pain in their butt, because I'm policing this so hard. I'm saying to them, like, look what this person did, look how this they marketed it, look what they said, because we need to improve that, right? It can ruin it for everybody, and that's not what we want to have happen.
I wonder, would you also speak a little bit too, so that kind of explains, maybe the goal, or what might each kind of session look like, but how much can each person expect to come? Just so someone would understand how many times or how often, or I'm sure it's a bit individualized, but I don't know the answer to that question.
It is individualized. A lot of that has to do with the intensity of the electromagnetic energy, right? So we're very much individualizing that. I would say if they're just using the HIFEM, so the high intensity focused electromagnetic energy, you're typically going to have approximately 6 sessions on the chair. Some do more, but typically 6. And I always say it's like a course of antibiotics. What's been studied is what we're going to do, and the majority of the studies have all shown effectiveness after 6 sessions, and so that's our starting point. There are some clients where, and again, because we've treated more people than anyone in the world, we know, we have a good sense of who might need a little bit more, who might not. But that's a decision we're making as we're going through treatment with the client. We're charting, we're looking at their scores, we're doing ICIQ, UI throughout. If we think they've got central sensitization, we're doing that index early on. We're not allowing them to start until we deal with that. Like, there's lots of metrics that we're doing along the way to make sure that the client's outcomes are the best they can be.
Actually, that brings up a question. Just, I know you've touched on it, Sinead, but then can you speak to that a little bit more? Because I think you already mentioned that, sometimes physios are a little bit reluctant because they hear, yeah, Kegel. And so now you're talking a little bit about, I know, Erin, you're touching on that when you talk about central sensitization, but will you talk a little bit more, Sinead, about, for physios listening, or maybe potential clients listening that have heard before, I'm not supposed to tighten my pelvic floor more. So can you speak a little bit to me, how would someone coming in that, has symptoms, that maybe, their assessment or something that you take out of the assessment gives you the suggestion that maybe, they don't need Kegel. What happens then?
Okay, yeah,
How do you integrate this?
for sure. So one, I would first say the emsella chair actually doesn't do Kegels. The emsella chair actually takes your pelvic floor through a very, very sort of fitness program. Is it creating submaximal sort of contractions? Well, yes, but it's not those contractions and then held for 8 seconds and kind of having that same impact. So I would first say, well, we have to step back a bit and just remember that that's actually not even what the tool does. Okay, so that's one thing. The other thing I think what we have to do as physios is, pelvic PTs, particularly from an Ontario context, started to be trained in almost like this dichotomous thinking, like it's either like tight or weak. And we are going to have symptoms of urgency when it's tight and all these things that actually we know is not the case at all. It's way more, nothing falls into baskets like that, right? And so actually, and one of the other things we've discovered as PTs is that our internal palpatory assessment isn't exactly as airtight as we thought. There's a lot of error that can come. We can make a lot of assumptions with that type of exam, right? And so what I think physios need to take a step back on and think is, okay, you just talk to the person. Are you honestly thinking that some of the actual connective tissue is very, very shortened? And really, we're going to have like an accommodation problem in the pelvic floor. And you're going to really, that's going to feed into kind of what your exercise prescription might be. Or is actually things presenting more like the pelvic floor is going to be in a bit of a protective state, which is usually more commonly what we're faced with. Well, if it's the latter, and we're thinking there's this kind of protective mechanism coming on, well, that then dials us to the concept of ramp up and central sensitization. So that's why one of the things that all of our PTs do as part of their initial assessment is they all run the CSI-9 for every single person. One, I honestly don't believe a PT can really map out a very informed, individualized care plan from the life coaching perspective without that data, because that's an important piece of data that's giving you a bit of a snapshot of their physiology. But also it's going to clue you in to if a tool that's in a high intensity anything, like forget the Kegel part, but high intensity anything doesn't mix with really ramped up central sensitization, right? So we want that flagged. So it's like, great, central sensitization is an issue. We don't want high intensity anything. And in a modality or even you like going for runs, that's not going to be appropriate. High intensity doesn't mix with that. So I do think there's a lot of stumbling blocks with something like this for PTs, because I think some PTs have dichotomized things probably incorrectly in their practice. and then keep forgetting that this thing actually doesn't do Kegels. And actually what's more important generally is protection responses and amplification than thinking about tension or tightness, right? So again, we've kind of really been able to like map all that out really, really nicely in this care model. And it's probably one of the reasons why the outcomes are so amazing. I can't tell you how many of our PTs, because they work on our team at Compass Rose Wellness Urospot, but then they kind of also have like their jobs elsewhere. And how often they're saying, oh my gosh, I'm now starting to apply all the things they're learning and the mentorship they're getting from me to their other places and getting way better outcomes, right?
And Melissa, I would say clinically, just so you know how that happens in front of a lay person, because central sensitization and high tone and like these are all terms that the lay person is like, what are you talking about? So if in our assessment, which again I said is qualitative, but we are asking a ton of questions, and the PTs who've seen it are like, you guys ask more questions than we do to assess potential high tone. What we are clear with the client is it's not a contraindication to using this technology. You're still able to use this technology, but because we are experts in this, and what we recommend right now is that you see one of our pelvic health physiotherapists first, because we want to understand what's going on in your life, what's going on to cause the central sensitization, and let's deal with that before we go and apply all this energy. So it is not a, you can't do treatment here, or you can, it's a bit of a pause, and it's the right, care. And that's where I worry with people who go seek this at a Botox clinic or something like that. You can guarantee that's not happening, right?
Well, it's like you're trying to fulfill the level 1A requirements or like the level 1 recommendations before you move on, right? So just to clarify, I know, so would you say that you're most often appealing or applying this to people with symptoms of incontinence? I know that there's, it's showing benefit to others, but would you say that you're trying to kind of keep it with incontinence, or will you speak to that a little bit about kind of who's
Yeah, we're not limited to that. We really are trying to encourage people who are having pelvic health challenges to come in a non-threatening way where they feel very safe and comfortable, and let's just learn about it. And it may be that we're not the solution, right? But we can help direct them, because most of them just don't know what's going on. And so typically, yes, I would say the number one thing we see is incontinence, all forms. So including fecal incontinence. And that's one where physiotherapists in the community who are really aware of our care model, they do refer fecal incontinence a lot, because we see excellent results with that as well. But so stress, urge, mixed, yes. Frequency, so high frequency, we see great results with that. Nocturia, incredible results. So that's one we're really excited about, because sleep is just so important to our overall health, right? So that's really improving quality of life when we can improve that, and that's for men and women. And then early stage pelvic organ prolapse, we see incredible symptom relief. That's the number one thing, is I don't have as much pain. I don't have as much pressure. That heaviness is gone. We've had some people who've actually gone to their doctor, they've come in and said, I'm at stage 3. We've done treatment. They go back, they're at stage 1. So we would never in a consult ever claim retraction, but just so you know, clinically we have seen it. But we talk more about in that situation, just symptom relief. And then sexual function. I didn't mention sexual functioning, but incredible results there. So women are like, they come in, they're like, I'm thinking about sex again. My libido's back. I want to have sex again. I can't believe it. So just all that increased blood flow to the region that's happening during treatment with HIFEM is helping with that as well.
So I have this client in mind actually that I think would be a perfect candidate. I feel like we've tried a lot of different things, and but we do not have this option in BC right now. Can you talk a little bit about where, I know Urospot, I think most locations are in Ontario right now?
Yes. So coming soon to BC, we have 22 locations across Canada. 15 of those are open right now. The rest are in development. So we're in Calgary and Edmonton, soon to be Saskatchewan, lots in Ontario. And Victoria is about to get going here. So we should be in Victoria this year, and then hopefully Vancouver this year as well.
Another thing I think I have to make sure I ask about so people understand is what can they expect when it comes to cost? Because I know we've alluded to the fact that this is a more expensive treatment than sometimes others. And that obviously, you know, the cost of some of these incontinence products and the cost of your quality of life being affected have to be taken into consideration. But just will you lay out a rough estimate of what people can expect to pay for this?
Sure. And I'll do it kind of talking about a national perspective. So depending on the city that you're in, most likely the investment you'll be making is somewhere between $1,800 to $2,000. If you're under the care of one of our physiotherapists, you'll end up probably, depends on how many sessions, but somewhere around a little over $1,000 in receipts for physio, that if you have benefits, you'll be able to claim that portion of the care. And then I always let people know if they have a healthcare spending account or a wellness account, that can be used as well.
Right. Ladies, just if I kind of tie together some of the things that I think we're trying to bring, you know, awareness to, is that I think that no two people are the same, and it's just our job as practitioners and educators and is to let people know of their options and then how they kind of like are laid out when it comes to the evidence. What do we know from the evidence? This is kind of how everything stacks up. However, you don't have to start in any one particular place. It's our job to educate you. It's your job to decide. I think that we need to be transparent and, like Sinead mentioned, not decide how people spend their money, because I think sometimes we spend money differently than our clients do. And it's just, again, falls under, it's our job to educate, not to spend their money or decide where to spend their money. I think too, just, you know, for people listening to think about, do their homework and look into some of the treatment options, because you know, when it comes to spending money, maybe you also want to do it wisely, and that there's a difference between kind of your long-term healthcare and a band-aid treatment. You know, be thinking about what are these people marketing, and what are they, what you know, what would be the long-term goal of this? It sounds like, and another important message is that this technology, in this case, like HIFEM, has a place in healthcare, but it shouldn't be used as a standalone treatment. What else? What else do you think is in that just to, as a therapist, keep up to date on the information and make sure you're educated too? So that, and it's hard sometimes to keep up to date on all of this information out here, but that's on us too as healthcare providers.
Yeah, I always want sorry, Sinead, I want every pelvic floor physio in Canada to know that if there's a Urospot nearby, please come in. We'd love to meet you. We want to know all the physios in our community. You're welcome to come in and, you know, learn more about our care model. We welcome you with open arms.
Yeah, what I was just going to say is one of the things that Urospot's done a nice job of is just right on their website. They have all the research right there. And again, like a lot of those research papers are specific to the technology, but that's not what Urospot is. Urospot is the whole care. The technology is just like a little part of it. So I think that's another important thing to remember. And then I guess the last thing I would say, and this is more, I guess, for our colleagues, but just to remember a point that Erin said at the beginning around help seeking. Help seeking is still really, really low. So I know that, you know, a lot of physios are sometimes thinking about a tool like this within the context of their model, that a client first comes to see them and then they're thinking, oh, this might work in with my client's care model. But I think one of the things our colleagues have to understand and hopefully recognize is actually a really good thing is that the way the PT model runs through Urospot is almost flipped the other way. Its clients are really hearing for the first time, because of exquisite marketing, right? That really most of us as healthcare providers don't do very well. So a company like Urospot is doing this really well, and they're thinking, oh my goodness, there's actually a solution to my problem that doesn't involve medication or surgery or things poking and prodding me. Okay, I need to learn more. I just didn't think this was possible. And they're coming forward. So it's like they're coming forward and then Urospot saying yes, and PT can be a part of this, and frankly should be, because your outcomes are going to be better, right? So we don't have this type of help seeking success in pelvic health in the usual way we do it. We just don't. And that's one of the things that really makes me so excited to be, collaborating with this company, because, the help seeking part is a big, big part of our care. And the traditional way we're doing things in healthcare doesn't optimize that, unfortunately. So rather than our colleagues being like closed-minded and feeling threatened and like the status quo is sort of the way to go, I would love it if our colleagues could just reflect on this conversation and be a little bit more open-minded to see all the good that is being done. Because it is really a lot of good that's being done.
Yeah. I would also, if I was sitting in front of some PTs, what I always love them to know is, I'm a female entrepreneur, you're a female entrepreneur. And Urospot to me personally is also a platform for women. So yes, we're helping change women's quality of life through pelvic healthcare, but I want them to know that every Urospot is owned by a woman. I created this company to create more female entrepreneurs. And so through creating a franchising model, I'm able to help women become their own boss, leave careers they might not be happy with, and open a Urospot in their neighborhood to help empower and change lives there. And at the same time, all of the PTs that we collaborate with are all women as well. And we've provided this great growth opportunity for them and an ability to maybe work a different way that works better for their lives as well. So, overall, it's a platform for women. And that's what I always want women, our pelvic floor PT community to know as well.
Right. Well, I appreciate all that you're doing. I'm sure you've had to have some pretty thick skin at times to, be able to kind of give your rebuttal or, keep saying, I'm sure, the same things over and over and over again. And I think, it's exciting to see change. Like how much is just even, just because I'm talking about you, Sinead, because you're a physio too, but when you first walked by that chair and just kind of like, oh my gosh, I would say that I share that sentiment, especially a few years ago when there'd be lots of blog posts coming out and everything kind of just like, oh my God, can you believe this chair? And I was kind of caught up in that too, because yeah, it didn't really make sense to me, but sometimes we take things at face value without kind of diving in and really thinking about it. And the more I thought about it, the more I'm like, this is just another modality. We use these all the time. I would never use a modality in isolation. But it's just in a lot of settings being used in isolation. And, but this conversation is so helpful to be able to kind of listen to some of that nuanced discussion and help people see, how you can marry so many different things and it's just another option, right?
Yeah, that's right.
Exactly.
So again, thank you both for this discussion, for your time. And I look forward to connecting again. And, you're doing great things. I appreciate all your hard work.
As are you, Melissa. Thanks for the opportunity.
Thanks, Mel.